Hello, guys. Welcome to this recall session of psychiatry. I am Dr. Prashant Agrawal, your psychiatry faculty, and we are going to discuss the questions of psychiatry which were asked in your last July 24 Fmge exam. So, let's start our discussion. This discussion is totally recall based. I have got questions from so many students and I am presenting you as the recall questions. So questions may have a variation from original questions that were in your exams. So, but the questions are almost similar, I hope. First MCQ of your FMG exam. A person has a fear. A person has fear of seeing tall buildings and looking down from height. He is suffering from what? So person has a fear of seeing tall buildings and he is very scared when he sees down from height. So basically here patient is having fear of height. Here patient is having fear of height. Fear of height means patient is having phobia. Patient is suffering from phobia. We have discussed n number of times about phobia in our classes. So I hope you have marked this MCQ correctly. So he is suffering from what? Claustrophobia, nomophobia, agoraphobia or acrophobia? Just tell me please. Come on, hurry up. So this patient is suffering from acrophobia, fear of height. Acrophobia, fear of height. So correct answer is option number D. What is claustrophobia? Yes, fear of closed space. Fear of closed space is known as claustrophobia. Even I have discussed about nomophobia in our classes. What is nomophobia? It is no mobile phone phobia. So nomophobia means fear of losing mobile phone. Fear of losing mobile phones. Nomophobia. What is agoraphobia? What is agoraphobia? Yes. In agoraphobia, patient is having fear or anxiety from two or more of the following situations. Patient is having excessive fear or anxiety for 6 months, for two or more of the following situations. Excessive anxiety or fear from using public transportation. Using public transportation like traveling in plane, ships or even train. Excessive anxiety while the person is in closed space, when the person is in open space, when person is standing in line, or in crowd, standing in line or in crowd. When person is outside of home alone. So if person is having excessive fear or anxiety from any of these two or more conditions for 6 months, then it is agoraphobia. So we all know about agoraphobia. So the correct answer to the above question is acrophobia, fear of height. Acrophobia, fear of height. Okay, next MCQ. Again, this is a repeat one and important one. We have discussed n number of times about alcohol withdrawal delirium in our classes, and I have told you that you may 99% get question related to alcohol, and this is the question of Fmge exam. So if you have attended the classes thoroughly, if you have revised the notes properly, then you have marked this answer correctly. So now let's discuss the question. A chronic alcoholic person was taking 500 ml of alcohol for last 20 years, presented with sensations of insects crawling on his body. That means person is having hallucinations, tactile hallucinations. Patient is agitated, means restless and irritable. There is agitation and irritation. Person or patient has taken last drink, or patient took, person had taken last drink 3 days back. Means almost 72 hours has passed since last drink. So which complication patient develops after 48 to 72 hours of last drink? Patient develops delirium, and in delirium there are visual hallucinations as well as illusions. So here examiner has mentioned clearly that patient is having sensation of insects crawling on his body. That means patient has already developed hallucinations and time elapsed. It is 72 hours after last drink. So definitely patient is suffering from alcohol withdrawal delirium. So correct answer to this question is option number B. It is delirium tremens or alcohol withdrawal delirium. It is not alcohol toxicity. If you use your common sense, then you will get to, get to know that this is not alcohol toxicity, because here patient is not consuming alcohol. Patient has stopped alcohol, yaar. So it is not alcohol toxicity. Why not delusion? None of the symptoms of delusion are mentioned in this question. So this is not delusion. Reaction with alcohol. Patient develops reaction to alcohol when patient drinks, consumes alcohol over disulfiram or disulfiram like medication. So here again nothing has mentioned about disulfiram or like this. So this is not reaction with alcohol. Second important thing, again common sense. Patient here has stopped alcohol. Patient is not consuming alcohol. So this is not reaction with alcohol. Patient is already taking alcohol for last 20 years. So if he has developed reaction, he would have developed years back. So this is not reaction to alcohol. So correct answer to this question is alcohol withdrawal delirium, and this is one of the simplest MCQ of psychiatry. Third MCQ. A patient is presented to emergency with problems in eyes. Patient is having diplopia, double vision. Problem in walking. There is ataxia. And he was confused, means there was global confusion. So that means patient is having symptoms of GOA, global confusion, of thalmoplasia and ataxia of gait. Patient has developed bilateral lateral rectus palsy. That is why there is diplopia, double vision. And when patient develops Goa, when patient consumes huge amount of alcohol. So history of alcohol was noted in the patient. What is the first line of management? So here patient is suffering from, very good, Wernicke syndrome. Here patient is suffering from Wernicke syndrome, and patient develops Wernicke syndrome because of deficiency of thiamine. So correct answer is option number B. Here patient is not having any kind of alcohol withdrawal. There are no tremors, no hallucinations, nothing is mentioned in the question. So there is no use of giving lorazepam. We do not give plain IV fluids without thiamine in alcohol dependence patients. Why? Because giving fluids, dextrose, may precipitate Wernicke-Korsakoff syndrome. So again, there is no use of giving IV fluids. There is no use of giving olanzapine. Why? Here patient is not suffering from any kind of psychosis. Patient has developed Wernicke syndrome because of thiamine deficiency, which occurred because of alcohol use. So the correct answer is option number B, thiamine. So I hope you all have marked the answer correctly. I hope so. Next MCQ. Now tell me the question. Now tell me the answer. This is a slightly tricky and difficult one for most of the students. Which of the following is not a defense mechanism? First of all, tell me what is defense mechanism. When you fail in your exams, what excuse you give to your parents, your colleagues, your friends? I was ill. I was ill. I have not seen the questions properly. I was suffering from this, that. So we are defending ourselves. We are defending ourselves from others. So ourself means our ego. Our present behavior is behavior of ego. So we use various defense mechanisms. One of the examples of defense mechanism, let's say somebody suddenly lose his or her loved one in accident or in any way. What happened to that person? That person will say, no, I haven't lost my loved one. He or she is there. This news is fake, not true. So he or she is not accepting the reality because he is trying to defend his or her ego by denial, by denying the acceptance of bitter truth. वो एक्सेप्ट नहीं करते हैं, नहीं वो जिंदा है, ये न्यूज गलत है, मैं नहीं मानता. This is denial. If you ask any person who is suffering from alcohol dependence syndrome, that person will say, I am drinking alcohol because of my wife, because of my parents, because of my friends. They are forcing me to drink. So I am giving excuse. I am defending myself. I am defending myself by giving excuse. All these are examples of defense mechanisms used by ego unconsciously. Sometimes consciously and sometimes unconsciously. Okay. So there are various different types of defense mechanisms. One, I have told you, denial. When person does not accept the bitter truth, denial. One is displacement. From the name itself, it is clear. When my senior scolds me, I scold my junior. So I am displacing my anger towards my senior on my junior. This is displacement. So basically it is transference of anger from one person to another person, or transference of feeling from one person to another person. Displacement. Altruism. What is altruism? Altruism is a type of mature defense mechanism. It is a type of mature defense mechanism. Person does good things for others. That is altruism. Doing good things even after suffering. If I do suppose I am donating 5 lakh rupees to this relief fund, but because of that donation my family will not be able to survive, means not be able to sustain properly or manage properly household chores for 5 or 6 months. Even after that I am giving 5 lakh rupees to donating money to relief fund. This is altruism. Doing something good to society. Okay, this is altruism. So this is a mature defense mechanism. Sublimation is also a kind of mature defense mechanism. Sublimation is also a type of mature defense mechanism. So we are left with, so I have told you sublimation is also a type of defense mechanism. Displacement is also a type of defense mechanism. Denial is also a type of defense mechanism. Altruism is also a type of defense mechanism. Replacement is not a type of defense mechanism. So correct answer to this question is replacement. There is no defense mechanism called replacement. There is nothing term, there is no term like replacement in defense mechanism. Clear? So there are so many different types of defense mechanisms there in psychiatry, but there are so many, so I don't think it is much important for you all guys. So you should know basic defense mechanisms. One is denial, displacement, sublimation, altruism. These 4 are important for you guys. So replacement is not a type of defense mechanism. Okay. Now tell me the answer. This is again very lollipop question for you all guys. A patient was taking metronidazole. It is pharma cum psychiatry MCQ for diarrhea. Patient went to attend the party of his friend where he had alcohol. Patient has consumed alcohol. Patient is already taking metronidazole, and over metronidazole he had consumed alcohol. After that he started having red rashes, itching all around his body. There is headache. What can be the cause for this condition? Metronidazole produces disulfiram-like reaction. So metronidazole metronidazole produces disulfiram like reaction if patient consumes alcohol over metronidazole, it produces similar reaction like disulfiram. So this is drug interaction or disulfiram like reaction. Hope it was there in your MCQ. It is not cheese reaction, because we all know cheese reaction develops when somebody consumes food containing tyramine. And if person is taking MAO inhibitors, if patient or person is taking MAO inhibitors, and over MAO inhibitors if somebody consumes food having tyramine in it, then it produces cheese reaction. So it is not cheese reaction, it is not methanol poisoning, because patient has not consumed alcohol after purchasing it from some local shop, something like that. It is not there in the question. So this is a clear cut case of disulfiram like reaction. So the correct answer to this question is option number B. Clear? Now tell me the answer. Again, we have discussed this MCQ multiple number of times in our classes. A mother is complaining about her young daughter that she has started behaving weird about her food habits for last few months. Her daughter means she eats a lot and then she vomit out. And she vomited out as she is scared of gaining weight. So initially she consumes large amount of food, eating huge amount of food or large amount of food in short period of time. After eating food, she feels that, oh, now I will gain weight. Then what she will do? She vomit it out by inserting hand or by using emetic agents. She has also indulged in over gymming because she wants to prevent weight gain. What is the most probable diagnosis? Is it anorexia nervosa? Is it bulimia nervosa? Is it pica? Is it binge eating disorder? What will be the answer according to you all? यहाँ पर जो बेटी है बहुत ज़्यादा खाना खा रही है और खाना खाने के बाद उसको लग रहा है कि अब उसका वजन बढ़ जाएगा, इसलिए वो क्या कर रही है? वॉमिट कर दे रही है। और वो जिम भी ज़्यादा कर रही है क्योंकि वो वज़न बढ़ने नहीं देना चाहती, लेकिन उसको खाना भी है, वो खा भी रही है और खा के फिर वो वॉमिट कर रही है। तो ये पहली चीज एनोरेक्सिया नर्वोसा नहीं हो सकता. इट इज नॉट अ केस ऑफ एनोरेक्सिया नर्वोसा. व्हाई? बिकॉज इन एनोरेक्सिया नर्वोसा फर्स्ट थिंग person or patient has low body weight. So here patient is not having low body weight first. Second, weight loss is achieved via starvation or fasting. Patient does not eat food, rather they throw food out of roof, out of window, below dining table, and they consume very less amount of food. So nothing is mentioned like that about in this question. So it is not anorexia nervosa. Here person, rather patient is eating large amount of food. Second, why not binge eating disorder? In binge eating disorder, patient eats large amount of food, but they don't vomit it out. They eat, but they don't vomit it out. So it is not binge eating disorder. Why not pica? In pica, patient consumes non-eatable things like chalk, paint, mud. So here nothing has mentioned about non-eatable items, so it is not pica. So we are left with bulimia nervosa. Definitely it is a case of bulimia nervosa, when person or patient consumes food and after that vomit it out. That is a case of bulimia nervosa. Correct answer is option number B. Again, very easy one. A known case of depression, patient is a known case of depression in the past who got recovered completely. Now patient is all right for last 5 years. Patient was a old case of depression. Patient has developed this depression 5 years back. Now he is all right. Means for last 5 years patient is all right. After 5 years, patient started to feel low, hopeless about future, developed negative emotions and lack of interest in routine activities and become depressive. What is the likely diagnosis? So if you read this question carefully, you will find what patient has again developed episode of depression after 5 years. Here patient is having anhedonia, patient has lost interest in routine activities. Patient is having negative thoughts about future, that means hopelessness, having low mood, patient is very depressive. So definitely patient has developed another episode of depression after 5 years. So when any person or any patient who develops 2 episodes of depression, any patient who develops 2 episodes of depression separated by gap of 2 months. Suppose patient has developed depression. This is the first episode of depression. Patient becomes all right after 2 months, maybe 3 months, after 6 months, and patient remains after becoming all right, after recovering from depression. If patient remains all right for minimum 2 months, and if patient again develops episode of depression, this is known as recurrent depressive disorder. Patient is developing depression again and again. So recurrent, again and again depressive disorder. Again and again depressive disorder. So the correct answer to this question is recurrent depressive disorder. Option number B. This is the answer. Why not acute psychosis? For psychosis, we need delusions and hallucinations. So neither delusion nor hallucination mentioned in this question. So it is not psychosis. Why not dysthymia? You might think that, oh, patient is having symptoms after 5 years, 2 years, something like that. You think like that and you may end up marking dysthymia as your choice. But what is dysthymia, if you remember? When patient is having low mood continuously for 2 years. Patient is not having fully depressed mood, rather patient is having low mood continuously for 2 years. So here patient was absolutely normal for last 5 years and recently patient has developed symptoms of depression. So this is not dysthymia at all. Why not bipolar? If you know what is bipolar disorder, we have discussed bipolar in our classes. What is bipolar? Either patient is having episode of mania or mania with depression, bipolar disorder. So none of the symptoms or no information about mania is mentioned in this question. So there was no manic episode in the past. No symptoms of mania at present. So nothing like mania is mentioned in the question. So patient is definitely not having bipolar disorder. So patient here is having recurrent depressive disorder. So these are the 7 MCQs of your July 2024 Fmge exam. And if you have attended the classes thoroughly, carefully, religiously, then you have marked at least 6 out of 7 correctly. Each and every MCQ is important for your future. Again, I am repeating the same line. Unless you pass this exam, you remain 12th pass candidate. So we all hope for the best. I wish you all good luck. Take care. Enjoy your life till your results. If you pass the exam, I hope you all will definitely pass the exam. You will clear your exam. This is my wish to all my students. But if something bad happens, then don't worry, we have another chance in December. So there is no need to worry. We have done our hard work. We have given our 100% in our exam. Even after that, if we do not able to pass the exam, then it is our bad luck. In that we cannot do anything. That is our luck. So with this note, I am ending the session. All the very best. If you face any challenge, any problem in your life, professional, personal, educational life, anytime,